Also, on behalf of the European Society of Cardiology, I would like to say thank you very much that we can be part of your fantastic Congress. And of course, coronary artery disease and chronic coronary syndromes are very important in the world of cardiology. In 2024, this year, about 2 months ago, we published a new guideline on the management of chronic coronary syndromes. This guideline replaced the previous guideline from 2019. In 2019, the name was changed. We used to call the disease stable coronary artery disease, but in 2019, the previous guideline, after long discussion and thorough consideration, the terminology was changed to chronic coronary syndrome to express that this is a disease that is not stable at all in many patients. It can be very dynamic. Patients are at risk of developing acute coronary events, and very intensive management is required to keep the patient's risk low. And this is why this terminology was maintained, chronic coronary syndrome, in the new guidelines. Another thing was changed with the new guidelines. We all used to speak about typical angina and atypical angina, but the new guidelines say that this terminology should no longer be used. There is a number of reasons for this. Number one, it has changed so that more patients present now with atypical symptoms than they present with typical symptoms. So atypical is no longer atypical. Also, the prognosis, many studies show, between what we used to call atypical angina and typical angina is the same. And also, the terminology neglects the fact that many patients might present with shortness of breath as their presenting symptom. You can see here that for shortness of breath and typical angina, the prognosis is the same. So it's important that this is also reflected in the terminology that we use. So what do the guidelines suggest now for the diagnostic workup of individuals who have suspected chronic coronary syndrome? The basic assessment that should be carried out in every patient who reports symptoms that might be associated to chronic coronary syndrome is, on one hand, of course, the history and the examination, class 1 recommendation. Then the combination of tests, the 12-lead EKG, and a few blood tests, particularly to measure the risk factors, LDL cholesterol, kidney function. Glucose should be measured in every patient, class 1 recommendation for this, and also in every patient an echocardiogram to determine left ventricular function and possible differential diagnosis. The exercise EKG in many institutions is also part of the routine workup for suspected chronic coronary syndrome. It also still carries a class 1 recommendation as a diagnostic test. However, the guidelines emphasize that the exercise EKG, the accuracy is too low to definitely rule in or rule out coronary artery disease, but the recommendation that stress exercise EKG can still be used is mainly to provoke symptoms, to look for arrhythmias under exercise, and it's emphasized that it should not be done if the resting EKG is abnormal, because then the diagnostic value goes down even further. And also the guidelines say that if you have alternative tests available, in particular coronary CT angiography, you should not do exercise EKG. The next level of testing, what you do next with the patient, depends on the estimated clinical likelihood that the patient actually has obstructive coronary artery disease. And there's a new table that should be used, the guidelines say, to assess the type of symptoms. We now no longer call them typical and atypical angina, and to give a number of points for the type of symptoms. If you have chest pain as the main symptom, you can collect up to 3 points if the chest pain is in the typical place, if it's caused by physical exercise or emotional stress, and if it's terminated by rest or nitrates within a few minutes. For each of these items, you can collect 1 point. So a maximum of 3 points if the patient reports chest pain. If the patient, on the other hand, reports dyspnea, shortness of breath, you get 2 points. These points are not summarized. It's either one or the other. Then the guidelines emphasize that the likelihood of having coronary artery disease is strongly dependent on the absence or presence of traditional risk factors. So the guidelines say count the risk factors between 0 and 5 traditional risk factors, and you get 1 point for each risk factor that is present. And now with this information, the symptom score and the number of risk factors, there's a big table that you can see here in which you can determine the likelihood that the patient has obstructive coronary artery disease. You can see that it goes from 0% in a woman who has, is young and has only between 1 and 0 risk factors and only 0 or 1 points for chest pain. And the highest you can possibly be on this table is between 44 and 45% likelihood. That would be a patient who has a lot of risk factors, is at higher age, male, and has all of the symptom characteristics that are usually described for chronic coronary artery disease. Maximum likelihood is 45%. That's based on symptoms and risk factors. Now, this table might seem complicated, but it's broken down into risk categories. Less than 5% is called very low clinical likelihood, and no further testing is recommended. Between 5 and 15%, it's called low likelihood, 16 to 50% moderate, and 51 to 85% high likelihood. And more than 85% is called very high likelihood of coronary artery disease, and patients should go directly to invasive angiography for further workup. Now, the table gives a maximum likelihood of 45%. So how can you ever reach 85%? Based on the table, you can't. And this is why this risk estimate that is done based on symptoms and the traditional cardiovascular risk factors is modified by additional information that we might have about the patient. And this is actually what we always do when we see a patient in the clinic. So the guidelines say, look at the resting EKG. If it's abnormal, it increases the likelihood tremendously. The guidelines say, look at the echocardiogram. If it shows typical wall motion abnormalities, it increases the likelihood substantially. And the guidelines also say, if you have a prior chest CT of the patient and there's calcification in the chest CT, this also increases the likelihood. So based on the table of symptoms and risk factors, you can calculate the likelihood, but this likelihood is modified a lot, and you can't quantify how much by the additional clinical information that you have about the patient, particularly the EKG and the echocardiogram. Now, if you look back at the categories, 0 to 5%, very low, no further testing is recommended. Between 6 and 15% and between 16 and 50% for this risk category, coronary CT angiography is strongly recommended as the optimal test in these patients. CT angiography should be the test of choice if it is available and if the patient has characteristics that may allow us to expect fully diagnostic image quality. If the patient has atrial fibrillation, for example, or a very rapid heart rate, coronary CT angiography is not a suitable test. If you have performed an exercise EKG and the exercise EKG is completely normal, you can scale down the patient to the very low likelihood group and no further testing is required. For patients who have slightly higher risk, between 16 and 50% and between 51 and 85%, the guidelines say stress testing with a stress echo, stress SPECT, or stress CMR should be the test of choice. So coronary CT angiography for the lower risk likelihood and stress testing for the higher likelihood group of patients. And as I said previously, if based on your clinical assessment, you assume that it's very likely that the patient has obstructive coronary artery disease, patients should go to invasive workup with invasive angiography and the possibility to perform pressure measurements, intracoronary pressure measurements immediately. So this has not dramatically changed over previous years, with the only exception that based on studies that have been published, there is now a very strong recommendation to use coronary CTA when it's available as the first test. So this might sound complicated, but in fact, it's really easy. The guidelines basically say estimate the clinical likelihood and take the risk factors into account. That's new. There's a strong modification upwards if the EKG or the echocardiogram are typical for coronary artery disease. If you have no such factors, the EKG is normal and the echocardiogram is normal, the likelihood is less than 50%, and CT angiography is the best test that is recommended by the guidelines. But for higher risk, stress test or sometimes immediate invasive angiography is recommended. So this is the basically short summary of the diagnostic approach. Coronary CTA, as I said, has a class 1A recommendation as the first test for the likelihood between 16 and 50%. But the guidelines also say that it should only be performed in experienced centers and if good image quality can be expected. And the main factor here is heart rate. We know that CT angiography has substantially better image quality when heart rate can be brought down to 65 beats per minute or less. It's important because only when image quality is optimal, CT angiography allows to reliably rule out coronary artery disease. And if image quality is poor, we have lots of false positive diagnoses. So in these patients where coronary CT angiography cannot be performed with good image quality, then stress testing should be used instead. Now for medical management, if any test is positive for coronary artery disease, if any test is positive for coronary artery disease, risk modification is recommended, so either aspirin or if there's previously known coronary artery disease, clopidogrel, and also if patients have angina, anti-anginal medication. Invasive angiography should be performed, as I said, in patients who have a very high clinical likelihood, but in the other patients, invasive angiography for diagnostic purposes is recommended when the patients have remaining symptoms in spite of treatment, when they have extensive ischemia in stress testing, or when CT angiography shows high-risk anatomy, which is mainly left main stenosis, or stenosis that include the proximal left anterior descending coronary artery, as we see here. In these patients, invasive angiography is recommended because we know that these patients prognostically benefit from revascularization. Finally, a word on what is called ANOCA and INOCA. Angina with non-obstructive coronary artery disease, or INOCA ischemia with non-obstructive coronary artery disease. This is mentioned in the guidelines very prominently because we know that almost 50% of patients who receive a workup for angina or ischemia have non-obstructive coronary arteries. What do guidelines recommend in this case? When, based on the workup, we suspect the presence of angina or ischemia with non-obstructive coronary arteries, the guidelines say do a test of medication first. Make sure that all of the risk factors are treated optimally, and then try medications such as beta blockers or calcium channel blockers, and ACE inhibitors are also recommended. If symptoms persist under this treatment, then the guidelines issue a class 1 recommendation to bring the patient back to the cath lab and perform invasive assessment, particularly of microvascular function and potential coronary artery spasm. This is a class 1 recommendation, even though it will be really difficult to carry this out and perform all of this testing in these many patients, but only after a trial of medication to see whether the symptoms can be suppressed with medication. And with this, thank you very much for your attention.